This conference will now be recorded.
So I want to welcome everybody to the AnCan Advanced Prostate Cancer Group. Our meetings, as you know, are Monday, every other Monday and every other Tuesday. I'm Herb Geller. I'm moderating tonight, and I will hopefully do a decent job when I'm faced with a screen full of people. It's a bit daunting tonight, I will tell you. But let's start. So Peter, why don't you start with Dan and introduce Dan?
Okay, Dan was new at our meeting last week, and I told him that we couldn't get to him, but if he joined us this week, we'd catch him. I didn't know much about him, but he was on a Reluctant Brotherhood call last week, last Wednesday, that I happened to be on. So I heard some of his story, and I suggested he for sure come on tonight. And I will quickly introduce, he sent me an email, so I'll give you some background. Dan's in Kenosha, Wisconsin. His pathology showed 5 of 12 samples, but it came back as a 3+4. However, his Decipher score was up in the 97% risk. His PIRADS was 5. He showed possible extension into the left seminal vesicles, and he's being treated. He's got an appointment Wednesday with a radonc in Milwaukee, Dr. Colleen Lawton. Anyway, he has a high Decipher score. And he's got someone recommended he do Da Vinci robotic surgery. So we've not really talked much. My first recommendation is he needs to get a second opinion on his biopsy. The other red flag is the PSA is very low. It's under 1, 0.83. So I don't think he's probably getting the best care, and he might not be a low and intermediate grade disease with all those red flags. So that's my introduction. Dan, if you have anything you want to add quickly.
Peter, I'd just like to say that this gentleman is probably much better off in your group than in our group at this point, until we know that he's high risk, until we know that he's a candidate for hormone therapy. This is not really the right group. That's why we separate the groups. I mean,
I know, but my group's not for another week, and I think someone needs to tell him that he needs.
Well, but we can't handle everybody in this group, Peter.
Okay.
We cannot. I mean, we rely on our moderators to see that and to guide the men to the best group. And right now, that diagnosis does not fit the profile for this group. And Dan, I'm sorry, and Peter's group is next Tuesday. We're pretty rigorous in terms of who you're free to listen, but we don't have the knowledge and the expertise here for your type of diagnosis. That lies in Peter's group. Because
I understand completely. I'll just listen then, if you don't mind, and I'll try to join Peter's group
That's
Tuesday.
perfectly fine.
Okay, thank you.
Fine. Okay. So I guess the next, I'd like to move on to Bruce McClatchy, who is also new this week, right? Bruce,
yes.
Are you there?
Yes, I'm here. Do you hear me?
Yes.
Okay.
So the way we'd like to introduce you is we've got a series of questions here, which will help sort of place you and introduce you to the group, and then we can move on and then answer the questions that you might have for us. Okay.
Okay.
So, how old are you?
I'm 75.
Okay. And where do you live?
I live in San Francisco.
And when were you first diagnosed?
2014.
Okay. And at that time, what was your Gleason score and PSA level, if you remember?
My PSA was a 7.8, and after the surgery, I had surgery. After my surgery, the Gleason score was 4+3.
Okay.
I also had a decipher test.
And then where was that done?
UCSF.
UCSF. And so what happened after that? So you had surgery, and then
Yeah.
what else? What's this history after that?
Okay. Well, I'll try to be brief about this. Let's see. So, Dr. Carroll did the surgery, and after the surgery, I was in a gray zone. I had some extracapsular extension. I had an extremely small surgical margin. It was like no more than 1/10 of a millimeter. And what were the other? I think those were kind of the two main risk factors. And then the decipher test showed that I was about 2.5 times more likely to get metastasis within 5 years than my cohorts, and my cohorts were 4+3 and 8. So anyway, basically after all of that, I got radiation, and I got a mini pelvis radiation, and for 7.5 years after that, I had an undetectable PSA, and just recently, my PSA has begun to be detectable. It's now, but very small amount, but it's gone kind of like steadily up. And I think I might, after what you just said earlier, I might be the wrong fit for this group because I'm
Well,
not.
no, you're recurrent.
Right. So, so anyway, that's been my situation.
So what is your current PSA?
My current PSA is 0.03.
0.03.
Right.
So, and how do you think it? I mean, that is normally within the margin of error of most tests.
Well, I've heard this before. I guess I'd put it this way. I mean, about 5 months ago, suddenly instead of being below 0.015, it was 0.018. Then 3 months later, it was 0.021. And then 1 month after that, it was 0.03. So I'm getting it done every month. And so far, I've talked to Dr. Carroll's nurse, and she or the team considers that I am a low-level biochemical recurrence. And I'm kind of concerned about it, basically, because I don't really want it to keep going up. I mean, that's about what it amounts to. So.
Well, okay. Do you have, I mean, given that you've had surgery and you've had radiation, the next treatment for you, if you had biochemical recurrence, is systemic therapy. So have you thought about seeing a GU medical oncologist?
Well, I have requested the nurse, Dr. Carroll's nurse, is supposed to be referring me to an oncologist, and I haven't heard back yet about when that's going to be. They tell me that the first treatment, well, that what they say is that if it gets up to 1.5, they would do a PSMA
PET scan.
PET scan. And then the first treatment, apparently the first treatment would be more like, if I had cancer, it would be more like, what do you call it? The knife, kind of precise radiation.
Well, it depends.
So let me jump in here. Let me jump in here, if I may. Bruce, I have my notes. What year was it that you had your radiation, by the way?
The radiation was late 2014, early 2015.
And who and was it Albert Chang that did the radiation at the time?
No. I went to Dr. Kornguth at Golden Gate Urology.
Okay, so you didn't follow up with radiation at
UCSF, right?
UCSF. Yeah, I kind of remember. So let me tell you my own take on this. I think that it's wrong to offer men a ultra sensitive test without their consent. And frankly, if you had a regular test, you wouldn't see these fluctuations and it wouldn't put you through the anxiety that you're going through right now. And the fact is, you had an RP, right? You had,
Yes.
and then after that, you had radiation,
Yes.
and there isn't much that they're going to do until your PSA gets up to probably north of 0.2. I'm not sure what the 1.2 was, but it's usually right now somewhere between 0.2 and 0.65. They would do a PSMA scan. And so when a man is getting an ultrasensitive test and agonizing over what to do at this point in time, there isn't a heck of a lot. We're not going to intervene. They're not going to put you on hormone therapy yet because it's not clear.
Right.
And so my point here, I've made this point in the group, and I will tell you that we made this point to the AUA just recently, when we said to them, if you're going to put a man who either has had radiation or is in recurrence on a ultrasensitive test, you need to seek his consent. That's what he wants. If you want it, you can have it.
Right.
But
I have wanted it and I am having it. So they have my consent.
Right. But do you want this anxiety of what to do? Because there's nothing we can do.
Well, actually, I'm taking a whole bunch of things. I mean, I hope this doesn't sound too funny. I'm taking quite a large amount of different, like Chinese medical herbs, which may have some effect in lowering PSA, and I'm taking some other things as well.
But why?
I mean,
but why?
Well, because I don't.
Let me come back to you on this, okay? It's not just why. If you had a prostate, those Chinese herbs might be effective. We're not opposed to them. They can be good complementary medicine. But those are designed for people that have a prostate. That's not your situation. Your situation, Bruce, is that you may have recurrent cancer, and we treat that in a slightly different way. So what happens is that what I want to say to you, and I'd like other people to jump in here. What I want to say to you is you are treating this disease, you're over-treating this disease for the stage that it's at and getting yourself into a tiz when, if you hold on, if we wait until that PSA gets to 0.2 or actually probably to 0.65, we can tell if you've got recurrence. And if you've got recurrence, we can act on it. But to discuss, should you be taking these medicines? What should you do next? There is no science for that, to treat recurrence at 0.0 at the third decimal place right now, at least not that I'm aware of.
Right. Okay. Well, I won't say anything more about it. I've taken in what you say. But,
under 0.1 is considered undetectable. Under 0.1.
Right.
So you are concerned about something that's below undetectable on the average test. Okay? Under 0.1, you can go for a year, 2, 3 with that.
Okay. Okay.
I have a question. Have you been seeing or seen a genitourinary medical oncologist?
No, I asked that, Larry.
And what did he say? No, not yet.
No, and why
No.
would he, Larry, at this
Well, my
point?
only question is if he has these anxieties and he would like to think if he should do something, the best person to actually give medical advice would be that specialist.
Not if they don't know whether he's even diagnosed. I mean, I'm working with a guy right now who has upper tract urothelial neoplasm. They don't know what it is. Can I get him into a GU med-onc? I can't, because they don't even know what he doesn't have a diagnosis. So the
Okay.
first thing is we got to have a diagnosis. Now, when you go through what Bruce has gone through, he could have a tiny little bit of prostate, healthy prostate tissue that's doing that. And you know, this has often been the case. So the point right now is let it get up to a place where we can at least tell where it's at. We don't want to keep it down right now.
Yeah, I think that the theory is, Bruce, that if you're suppressing this, you're not going to actually reach a diagnosis if you need one. Right.
Okay, that's an interesting point. All right.
If you're artificially hiding data that could actually lead to treatment if you need it, if these
Okay.
drugs do anything, and we don't know. I mean, I certainly wouldn't be taking drugs where I wouldn't know what their basis of their effect was.
Okay. Yeah. Okay. Well, I mean, I think.
I think your best bet is to sit tight. And if it gets to an actionable level, people will jump on it. Peter Carroll isn't going to let you sit around with a PSA that's rising that's clinically treatable. He's going to send you to somebody who will treat it.
Right. That's true. Okay. Uh, I have my own thoughts about this, but it's too complicated to try to explain. So I probably should just go ahead and pass. And I'm probably in the wrong group for now, anyway. But
No. You're not in the wrong group, because your concern is, when I say that, your concern is recurrence. So men who have recurrence usually they're usually in this group. Since you've had recurrence and radiation, when I think about it, you're definitely in the right group. You're definitely in the right group, because you had recurrence, you had radiation, or you had adjuvant radiation. This is the right group. What we're trying to tell you, and you know, what Geoff mentioned, and maybe other people before we move on want to endorse that, is that you're, if it were me, I would consider this to be over response. There's nothing I can do when my PSA is so low. There's not much I can do. And taking all of these drugs are designed to reduce the size of a prostate. You don't have a prostate. These drugs are not designed to act on what could be potentially malignant cancer cells, prostate cancer cells.
well, I really hate to get into some kind of an argument here, but actually, these are things that have been studied, and they have an anti-cancer effect. Some men have experienced a lowering of PSA by taking these things. I mean,
Right, but they've had a prostate. They have an anti-cancer effect before you get cancer. Have they been shown to have an anti-cancer effect after you've had cancer in a recurrence?
But Bruce, I mean, let me jump in here. It doesn't really matter what you're taking. The bottom line is, at this level, a conventional oncologist is not going to think that there's a problem.
Right.
If you want treatment, the best bet is to get yourself off of these drugs, let your PSA reach its desired level based on what the level of your disease is. And then once that PSA reaches a doubling time where they can calculate a doubling time, where they can measure a measurable level, where they could do a PSMA PET scan to localize any disease, you'll be in a position to get some therapy. But right now, it's just not possible to treat it because the data don't support treatment.
Right. I understand what you're saying. However, this is I shouldn't even be going on and on about this. Actually, what I want to do is I want to, while it's very, very tiny, barely even noticeable, I want to kill it. That's my
How
idea.
could you do that?
Well, because these things that I'm taking have an anti-cancer effect.
Well, clearly they're not killing it because your PSA is going up.
Well, I just started about 2 or 3 weeks ago, so
Well,
I don't know.
I mean, I think the best bet is we're happy to have you in this group. Right now, I think the best bet is for you to listen and participate, and then keep us informed as to how your PSA is going based on these drugs that you're taking.
Okay.
And then
Okay.
if things are moving in a particular direction, I think we'd be able to provide better advice.
Okay. Okay. That's fine. That's fine with me.
And the other thing I'd encourage you to do is who's prescribing these? Are these being prescribed by the fellow out in San Anselmo, Michael? What's his face?
No. There's a there's an herbal mixture called PC Spec,
Right.
and
Yeah.
I looked at all the
We're
ingredients.
familiar with it.
I'm not taking that though. What I did is I ordered all of the herbs in bulk, and I'm drinking a tea twice a day
Right.
with that. And
Look,
let me just finish, please, Herb, because it's important because people listen in on this. So this PC spec may not have, but it is designed to try and prevent cancer early on. And what you need to look at is, have these herbs had any effect in a recurrent situation? That's what we're encouraging you to do. If you find that they are effective in a recurrence, fine. But PC spec is not something that is recommended in a recurrence. Now, your theory that I'm going to try and nail these right now, that's not what these drugs are known to do. And I'm a believer in Chinese medicine, but I don't think you're taking the right herbs. I think that you've logically decided this is the way to go. Personally, I think there's a flaw in the logic, but you should continue doing what you think is right.
Right.
Okay.
I think we ought to move on. And Bruce, I think given that you're taking these herbs, given that you have your PSA measured frequently, I think we'd like to hear about it, because I'd like to hear to see if it actually has an effect.
Right, exactly.
Right.
That's fine.
So let's collect. We'd like to have you, and we'd like to have your data. But from now on, but for today, I think we can just say we'd like to hear from you in the future.
Okay. Good. Thank you.
Okay, we need to move on. So I think another new person, if I'm not mistaken, is Neil Sundstrom. Is that correct?
Yes, and thank you. I wasn't going to be really talking here today, but I just wanted to add a couple of things. I very much things in common with Bruce here in terms of I went with Dr. Carroll as well. I'm in the San Francisco Bay Area. I had my prostate out using the Da Vinci in 2013, and in 2021. My PSA started rising, but it is through the ultrasensitive, and so it's not rising very much. It hadn't been detected before, but July 21 it was 0.04, October 21 0.06, March 22, 0.08, and then 2 months later, 0.09. So it's getting to almost the 0.1. So Dr. Carroll has, just Bruce, for your information, Dr. Carroll has recommended that I go in, which I will be going in August 1st, for transrectal ultrasound. I was recommended to have a PSMA, but with discussions with other urologists as well as with Rick Davis. Thank you, Rick. Appreciate your help. The PSMA was thrown out due to really it's way too early for that, and
Right.
not a useful test. So August 1st, I'll go for the transrectal ultrasound, and we'll see if that has anything. But again, I agree that so many points of discussion and so many doctors. I have some personal friends that are urologists. They've all said that until it gets to 0.2, there's really not a lot that can be done, and so and then treat it after that. So
Right.
we're on our way to that, it looks like, and we'll see what this
So
transrectal
great.
ultrasound
Well,
comes out with.
Neil, thanks for that summary. It's really a good segue from Bruce's situation,
Mhm.
because you're both treated by Peter Carroll, and your PSA is going up, and I think maybe there is a potential treatment plan. But I think you're right. It's just good to hear these stories.
Yeah,
So
and I think but to your point, the treatment plan, it's way too early for that. It's still the diagnosis plan as
right.
far as I'm
So
concerned. And
so
so that's
please
Right,
what we're working on, and until it
right.
gets to 0.2,
so
we're still
please
into diagnosis.
right. So please
And
come back with us and give us some
yeah,
updates.
I will.
so a couple of things. First of all, Neil, we've been supporting Neil since 2013.
Ah,
Um,
okay.
Neil, you've never seen, because Neil's a very good friend of a close friend of mine, an ex-neighbor, and so we worked together when Neil had his surgery, and so one thing to bear in mind is Neil was, I think, a 4+3, and so the cancer's been moving pretty slowly. And I'm assuming, Neil, that this is going to be a color Doppler transrectal ultrasound with Dr. Shinohara. Is that right?
Exactly,
Yes.
yeah.
So this is not a regular ultrasound that Neil's getting. And Bruce, this is something that possibly might be applicable to you, but maybe not, since you've had radiation. I don't know exactly what they radiated, what Kornbluth radiated. It's a color Doppler technology. It's something that Peter Carroll relies on. Shinohara is probably the best proponent in the country today. I had it many years ago. And basically what it's able to do is track down where there is higher blood flow. That's where the Doppler comes in. Doppler is a technology that is able to detect flow. That's why they use it for the weather. And so they're able to see faster, slower flow. And if they see a high blood flow, they can associate that with cancer, because the cancer requires a greater blood flow. And that's the kind of the principle of the system. So it's possible that and he's a wizard with this, Shinohara. He's an absolute wizard with it. So it's possible they'll see something. But what this brings up for me, which I think is really, really important for the group, is that we have to do a better job in managing anxiety in men around recurrence. And it's not just us that has to do a better job. We've got to talk to the doctors about doing it, because the doctors are placed in the same situation. A man comes in, he's very anxious, He wants to do something. The doctor really doesn't know what to do. So they start fishing out there. And I have a real concern as to how we're dealing with this. And maybe what we need to do, I mean, there's a new app that's being developed by Blue Note Therapeutics that you will put on your phone and will be prescribed by the doctor. And that application is around cancer recurrence, not necessarily prostate cancer. And I just think, and Dr. John, I think it's maybe really appropriate for you've been through this yourself. And you know, as a lifelong psychiatrist dealing with anxiety, what are your thoughts on what you're hearing from these two men?
It's a problem not just for these two men, as you say, but all of us. At the very least, we get scanitis and PSAitis, waiting for results of our tests, thinking that our whole future depends on what we're going to read in those lab reports. It's maddening. It's like a little re-traumatization of when we first got our diagnosis every time we get news. It takes away from our real mission of living every day without getting distracted by the future or the past. And it's a real major quality of life issue. Regarding the particular instrument that Rick is talking about, this is a company that asked us to help them participate in a research project for their instrument that draws from cognitive behavior therapy. We haven't really yet successfully referred somebody to use it clinically and then seen how things turned out. But if somebody is interested, we will help put them in touch and see if you can either be part of the study or maybe just get to use it clinically and pay for it. We don't know yet. But anything that we can direct you to help you with your anxiety, this distracting, maddening anxiety that we feel, we really very much want to do.
Thank you. And
Okay.
for those of you who came in a little late or you didn't hear, we are absolutely thrilled and honored that Dr. John has agreed to participate in the moderation team. So you'll be seeing him in future on that top line. And
Don't forget about the dulcet tones, Rick.
Right.
and here is dulcet tones, but I kind
Yes.
of feel that managing anxiety is more than detecting prostate cancer for people who are caught up in these 3-level ultra sensitive PSAs. I don't know. Is this something that anybody would like to comment on? Because it's an issue that affects everybody. And I don't want to sound like we're belittling it, but we're saying this is a different issue to the prostate cancer.
I mean, Rick, my only sense of it is that where the ultrasensitive PSAs are picking up data which can't be acted upon.
Yeah.
Right. Whereas, yes, PSA anxiety is with all of us. I mean, when we have a PSA that's in the actionable range or it's going up or going down, or we've been treated, that makes us feel better or worse. But when we're taking data that we know can't be acted on, I mean, you know, there is a theory in medicine, and I'm not a physician, John is, he can address this, is that if the result of a test, no matter what that result is, will cause the same action, there's no need to do the test. And the consequence is, if you're testing yourself at a level of PSA that won't cause any action, there's no need to do the test. All it can cause is anxiety. John, would you comment on that? I mean,
Well, absolutely. In fact, a couple of months ago, Herb had to straighten me out because my PSA went from undetectable to 0.019. So I thought my life was over and I was going nuts until Herb said to me, "Hey, wake up, 0.019. What are you talking about? It's a curse to get a result that doesn't mean anything."
So
We're men and
anybody else?
we expect that when we are faced with a problem, we are going to do something about it. So we hear something, we say, "Here's a problem, let's do something about it." But this is not anything we can do something about, and we have to somehow learn not to see it as a problem until we can do something about it.
Well, I don't know if this is better or worse, but I know insurance companies, medical insurance companies, would love to hear this portion because they always want to deny things and they say, well, it's going to lead to some curative treatment. So we should be able to get some money from them for saying this.
Well, I had the situation with the Polarify test where the doctor kept saying, "Why should you take it? It's not going to necessarily change the treatment." But in my case, it clearly would have changed the treatment if I had done it earlier. And we would have been looking to get involved in the Pluvicto or those things earlier. So how do you know?
Well, but Steve, obviously there's a case, and I would like to move on and end this little
Okay.
discussion but I think in your case, your physician was wrong.
Exactly. Well, and the point is that as we talk about these things, talking about them in black and it's important to qualify
Right.
things in shades of gray. So we don't make rules like that
Right.
allow people to deny us for really no reason.
Okay. So I think
Yeah, and a quick shout out. If you're looking at the screen, you may see that Steve is talking to us from a hospital bed in an intensive high-tech hospital bed in an intensive care unit, and just a huge shout out that we want you to get better quick. Steve had very
we're going to hear
serious
from Steve in
spinal
a minute.
surgery.
Rick,
Oh, we
Steve will
are?
tell us.
Okay. Okay.
So I guess it's getting late, and we've had several new people, and there are two new people, and I'm wondering if you would be willing to come next week if you don't have a pressing question. So I think that would be Glenn.
We should take Glenn this week because Glenn was here last week.
Oh, he was. Okay, fine. Then Glenn, you're next. Tell us.
Hi, I'm Glenn. I'm 69 years old. I live in St. Paul, Minnesota. I was diagnosed early this year. I had a MRI scan, and I had PSA of 8. Confirmed that with a PSA of 7 something a month later. Biopsy, I had 12 of 18 positive cancerous samples. Had Gleason scores of 7, 8, 9. The 9 was 4 plus 5. I got a PSMA scan.
So where are you being treated?
I'm both at the University of Minnesota and the Mayo Clinic.
Mm-hmm.
I can explain. Or go ahead.
Okay. And so who is your treating physician at the moment?
I had at Mayo Clinic, I had Dr. Mark Waddell for HDR brachytherapy, and now I'm following up with external beam radiation. I'm also seeing Dr. Antonucci at the University of Minnesota. He's my medical oncologist.
Okay.
I started Lupron in March. I started abiraterone in April. My PSA, I think, went down to 4 with the Lupron, and now it's down to 0.07. I met with Dr. Antonucci last week, and I think he said he expects it to go down to be undetectable.
Mm-hmm.
He asked me also to take a genetic test. I have a mutation in the PALB2 gene,
Mm-hmm.
and so that is part of what we'll be following as we proceed.
Now, was that a test that you took, was your genetic test of your germline or of the tumor?
Germline. I had radiation, so the tumor was
Right.
not
So it's right,
pulled out.
right. So it's germline. Okay.
Yes. So we're going to see a genetic counselor at the end of August. I have a daughter who's 26, so I'm hoping we'll get her tested soon too. I've also been having some emotional things. I'm having a really hard time just coping with day-to-day stuff.
So
Don't seem to. What?
go ahead. I'm sorry. I'm listening.
One of the reasons for that, and
Thank you.
again, one of the reasons for that, and Dr. John will jump in here, is that unfortunately, the lack of testosterone, the androgen deprivation therapy, totally throws your system. And so the emotional disruption, instability, may not necessarily be associated with you handling the cancer, with what's going on around you. It may be a chemical response to the fact that you're not producing testosterone, and the chemicals, the proteins in your brain are not forming in the way they did. And I'll just give you my own situation as an example before we go to Dr. John, which is that I was on medication. I was on an antidepressant because I have a long family genetic history. And so when I experienced depression after the ADT, it didn't scare the wits out of me, which it does to some men if they've never known depression before. And I spoke to my PCP, and he said, increase the meds. And I would increase the meds. It would help me, and then I would later on decrease the meds. Now, if you're somebody who's never been on medication, I would, if it were me, I'd be talking to my PCP about getting some medication to help me. Now, finding the right medication is a whole different story, but again, Dr. John, this is right in your wheelhouse.
Well, let me interject that I believe I was diagnosed with persistent depressive disorder at one time. I took medication for 15 plus years, and I don't know, it never seemed to make all that much difference. So I haven't taken any of that for 8 or 10 years now.
Mm-hmm.
I did also go to there's a local group in the Twin Cities called the Face It Foundation, which is a support group for men who have depression. And I spent 2 years going to that. Well, I was during the pandemic. They weren't being careful enough about masks, so I left that. But yeah.
So Glenn, how is it affecting?
Herb, let's hear from Dr. John.
Well, that's just exactly what I was going to say, Herb. Is it affecting you? Does it feel now like it felt when you got depressed years ago? Feel similar?
No, this feels more intense in the moment. I mean, tonight I tried to order a dinner online, and the order got lost. I went to the restaurant and waited for 45 minutes, and it felt really bad. And hell, it's just a dinner, but it really took me down.
Well, and I'm his wife, and I can attest to it's been a real struggle this last couple weeks.
Oh, are you filled with
And
fear?
what?
Filled with
Well,
fear?
it doesn't feel like fear. It feels more like hopelessness or worthlessness.
Oh, yeah.
And it seems kind of situational, but it's triggered by pretty small situations. So
Oh. Oh, yeah. Well, see, yeah, you should probably, I don't know, back then if you met any psychiatrists that you really liked, even though you didn't meet a medication that you liked, if you met a psychiatrist that you liked, call them up. And if you didn't meet a psychiatrist that you liked, maybe it would be a great time to find one.
So John,
yeah,
what about just a therapist without
Well, the
drugs?
problem is that you probably, at least with the psychiatrist, you also have the option of some medicine if it would help. Yeah, a therapist would be good, but then you might also have to find someone to prescribe if that would help.
So I have an idea for you. And I think that you're with a really good doctor at Masonic. I think you should ask if there's a psych oncology group in there. A lot of these hospitals have psych oncology groups, psychiatric oncology groups. If not, ask Dr. A for a referral to their palliative care group. So palliative care is about treating symptoms. It's not end of life. People think, oh, palliative care, that's end of life. No, it isn't. And that group will start working with you to find the right medicine for you. Because I really empathize. I get it. I get it. And these silly things bother you, and you say, why are they bothering me? But they do. And I think that as soon as you can find that a medication that suits you, you're going to feel 1,000 times better. I'm convinced of it, especially if you've been on medication before, but it wasn't the right medication. And I think the way to go about finding it would probably be through somebody that using Dr. Antonucci as the entrance and asking him, telling him that you need a psych med, and can he refer you to somebody at Masonic for it?
Yeah.
What would you say, John?
My question for the group is the one thing that he did, Dr. Antonucci said, because this is clearly tied to the medication, is that he felt that if Glenn's PSA dropped more, that he would be willing to talk about dropping the Adderall to 750 instead of 1,000, because he said that the 1,000 was pushed by the FDA, so they could get FDA approval, and the 750.
Right.
So my thought, and obviously this is not my area at all, that before we add he adds another medication, and reasonable to try.
Look, these medications are working in different ways. Finding the right balance of ADT, of hormone therapy, is one issue. That's what Dr. Antonucci is fixed on. But Dr. Antonucci is not talking about stopping the Lupron. So, and without that Lupron, you don't have the testosterone, and without that testosterone, you're not making the right proteins to keep you balanced. So yes, we can play around with that. That's a good solution, maybe a good solution, but it doesn't take away. It's not going to resolve. I doubt. I mean, John's the one to say this, but in my view, it's not going to resolve this anxiety and this depression. The depression more than that, the anxiety. And I think you need to be working. If it were me, I'd be working with a doc who could prescribe something to help me with that. and it shouldn't get in the way of fine tuning the hormone therapy. John or Herb?
It would be very good luck if a reduction of one pill of abiraterone
Yeah.
resolved the mood disorder.
No,
That would be a fantastic solution. It's unlikely, but it would be great luck.
yeah,
I
I mean,
I wouldn't delay treatment for a whole month just for something like that.
yeah, I mean, my own sense of abiraterone and the literature on abiraterone would indicate that it's really not coming from the Abbey. It's really coming from your major hormone disruption due to ADT. And I mean, I know John and I may disagree about this. And Rick, I really think that even a talk therapist who might actually help you through this hump dealing with these issues.
But you see, it's the reason I don't seek talk therapy for this is because this is being generated by an imbalance in the proteins.
Well,
this isn't a socially driven issue, Herb.
Well,
It's an issue that you don't have testosterone in your body.
Right,
yes,
but I'm not sure.
A talk therapist may be able to handle it better, but there's there is, and I've said this for years. There is a physiological change that takes place in us and in our brains when we don't have testosterone in our body, and we can't fix that with talk therapy. We have to fix it with medication.
Well,
Glenn, this is Peter, and I've been in your boat. I'm still in your same boat, and I found a husband and wife team. The wife is a therapist, the husband was a psychiatrist. I've been on medication from the get-go because this is a long journey. I'm 8 years into it, also a genetic mutation, also seeing Dr. Antonucci, and I can talk to you more about it, but I'll be in Minneapolis for the whole summer. It's there's nothing bad about taking a low-level therapeutic drug to just keep your mood up, because you're going to be in it for the long haul. This doesn't go away, this disease. It's at your level and my level. So a little bit of help. There's nothing wrong with it. There's nothing to hurt our egos on this one.
Excuse me, Herb.
Yes.
Just a point to make here. Anyway, I've been on the 750 milligrams, okay, Abby now for 57 months. So it is a doable thing, okay, if it helps.
Yeah, but Jim, we hear you, but you fortunately you were also on Lupron, and it didn't affect you mentally in the way, and it doesn't affect everybody, but it affects some people. And if you're prone to this, as Glenn is, he had a predisposition, I get how devastating it can be when the black cloud just descends on you. And while 750 may work well, as Dr. John said, that's probably not going to be the solution. And if it were me, I would be talking to somebody at Masonic to see if I couldn't get a prescription for some sort of therapeutic drug. And it may not be the right one. Now, this is the toughest thing, as John will tell you. You may start, the first drug I took, it made me worse. And then I had to get off it. I had to wait 2 weeks to clear my system. And then, thank God, the second one that I got was fantastic. And I've been on some form of that in different doses ever since.
So let me interrupt, Rick. Glenn, we've discussed, we sort of stopped listening when you mentioned this depression issue. Are there other things that you think we can deal that you're dealing with that we didn't discuss?
Well, I think I'm just experiencing some of the normal side effects of radiation. Bowel movements have been disruptive. I've been taking some Imodium to try and calm things down a bit, and I think otherwise I'm tolerating it okay. I've had a few episodes of fatigue, but not regularly. I don't know. We'll see how that goes. I still have a week and a half to go to finish this series. But.
So do you have any other questions for the group?
I think the emotional stuff was the main thing that was my focus tonight. Thank you. Thanks for all the advice. I appreciate it.
Rick and Herb, what about inviting Glenn to your Thursday night group?
Oh, for sure. Yeah. Glenn, are you, I don't know if we have do we have your email? I don't know if you've sent it to us. If not.
I think I sent it to Herb for the meeting.
Right.
Okay.
So I think that's how I got the meeting invite.
Right. So,
I can send
Herb,
it
if
to
you can send it to me, and I'll make sure that Glenn is signed up for the, and you'll get the meeting invites. We'll get you in the database, and we'll ask you to Men's Speaking Freely. And Men's Speaking Freely is a group that we run. It will be on the 21st. Is that? Yes, it's going to be on Thursday in this room at this time. And I think we should allow lead moderator, Mr. Jackson, who's sitting right up there, just to say a couple of words about, thank you for the entry, the segue, Gary. Rich, will you just say a couple of words about the Men Speaking Freely group, please?
Well, it has been mentioned, it's Thursday night, so we've got 2 to 3 days. It's a men's only group, so we can relax and discuss the things that we're embarrassed about, we're afraid of, that make us cry, that keep us up at night. It's a peer-to-peer group. Like this one, we don't give medical advice, but we have learned that the ability and the knowledge that someone else is having the same issue and that someone will take a moment to listen makes a major difference. We do meet once a month, third Thursday. Would be happy to have anyone here stop by. Again, it is men only, so we do kind of hold to that particular line. But the email should go out tomorrow afternoon, tomorrow evening, and we will discuss whatever anyone wants to bring to the table.
So it's Thursday. Thursday or tomorrow?
It is Thursday. The email will go out tomorrow.
Oh, okay, right.
The invitation reminder will go out tomorrow.
Well, thank you, Rich. And everybody's welcome.
Yeah, and for Glenn's wife, we do have a very good caregivers group. And
yeah, I did talk to one of them.
Okay. Okay.
Okay.
You're very welcome.
Glenn, please come back, both of you. We want to hear from you again, and we hope to see you on Thursday. In the meantime,
all right, thank you.
I would like to move on. Now, we'd like you to come back next Tuesday, because we really have run out of time for new people tonight. Hopefully that will be good enough. Oh, and then next disruption.
Is next week a fifth week?
No.
No? Okay.
No, Len's in the chair, and also the same for Stuart.
Right. So please come back next Tuesday. Remember, Tuesdays we meet at 6 p.m. Eastern in this same room.
Right, and I don't have too much of a problem, so I might not be needing it. It's okay. Thank you very much for the invite.
Okay, great. Okay, let's move on to our guys. And I do want to start with Steve, because they may turn out the lights in his room anytime now, right? So,
I think I have control over that here still.
so
At any rate, I guess to try to give a little bit of background where I am, I'm at the brand new, 3-month-old hospital room at the University of Pennsylvania Perelman Center called the Pavilion. And what got me here was that my back has been getting progressively worse over the last several months. And I've been really trying to tough it out to get through the clinical trial and get the treatment with the lutetium and the actinium. I had to go to New York to do it. Each trip became more and more difficult because sitting in a car while my back gets progressively more painful just keeps making it worse. And while it did, if I rested it and took care of it afterwards, it got better. But as it was getting better, it was never getting back to where it was before it got worse again. So having said that, I did get my second treatment of 2 scheduled of the 2 different radionuclides. And on Friday, I think that's July 8th. And when I came home, this time I asked my wife to go with me and I had somebody drive me. And when I came home, I actually fell in the upstairs part of our house going to get a shower to get the hospital washed off of me. And I did not really get any better with the back pain. And so ultimately, I reached out to Dr. Narayan, who I've been sort of a long interview process, round robin interview of medical oncologists. But at any rate, and he actually spoke to Ellen because I had fallen asleep on Sunday night. And he realized that I was really in a lot more trouble than I was describing accurately and convinced me to come down to Penn on Monday. I think actually he wanted me to come down Sunday night, but I came down Monday, had a horrible experience over maybe close to 20 some hours in the emergency room, which we can talk about if we have time, and ultimately was faced with the pain of 3 MRIs, the lumbar, thoracic, and cervical, them cutting the pain medication that I had worked out with my previous palliative medicine group, which is very helpful to have those guys involved. I really think it's an important topic of discussion to manage the pain medication when things start to hurt. And then ultimately Tuesday morning, maybe 10, 11 o'clock, something like that. After they examined the MRIs, they told me that I really ran a very high level risk of paralysis in a short period of time if I didn't have surgery to correct the stenosis and other compression issues that had been getting worse and worse and worse. As I was trying to treat one thing while some things were getting better, too many of them had deteriorated too much.
So Steve, the result is surgery. Is that?
Yeah, and it was very stressful because basically the neurosurgeon said, you have to make a decision now. My wife wasn't here at the hospital, my kids weren't here, and it was, you have to make a decision now. You either have the surgery today, or I don't know, it could take months, and it's a very high level risk that you will face paralysis. So ultimately, I did manage to reach around a lot of it with the help of Rick, speaking to Dr. Narayan, getting to understand why it had elevated, not that anything had changed, but why we were now recognizing that the danger and the sensitivity of it was really something that had required an immediate decision. I could choose to not have the surgery. In either case, the surgery there's nothing really about the surgery that's going to make me better or prolong my life, but it will more than likely, and seems, I feel comfortable that the odds of having a higher quality life for however long we have it are much, much greater based
So,
upon
so let me
having.
ask a question. Has the
Sure.
pain gotten less?
The pain related to the chronic part of the disease. So the answer is the pain that I have been getting worse over the last 4 or 5 months is definitely better. And the pain associated with the fact that I had a surgical procedure and a laminectomy and a lot of other things going on, screws and all kinds of construction work inside my back. That's certainly, getting up, getting around, that hurts. And I mean, that I look out for the time for the pain medication. It's important. But I do feel like, so one part of it has gotten better. I'm able to, to use my arm strength and my leg strength to maneuver around the bed. And as I think the things heal up from the incision, that it will continually be easier to deal with.
Let me ask one additional question. You had your double therapy last week, right? You had your
I
actinium
did, yes.
lutetium. Did they do a PSA before they gave you the actinium lutetium?
Yes.
And how
And
did
the
that
PSA was about, I'm sorry?
How did that turn out?
It had got, it's been hovering in the 120 to 135 range, and it went up to about 180, 190.
Huh.
My understanding is the immediate PSA when we're treating the bone disease like that doesn't give as accurate a picture as we'll get over time.
So
because the process of PSA dying seems to stimulate release of PSA.
Anyhow, Steve, I just wanted everybody to hear the story, see that you look good, and make sure that we're with you on all
I
of this.
appreciate. Thank you very much. It was very intense to have to make that kind of decision by myself. Over a period of an hour or two.
Right.
And with somebody, I just met the doctor. But
Right.
as I said, having people like Rick and Dr. Narayan and Dr. E sort of comment on all the thing, it helped me give me permission to myself to be able to evaluate the things that needed to be evaluated to decide where I wanted to go.
Great.
Where I want the odds to be.
Anybody else want to say something to Steve or about? Okay. Well, I mean, I'm certainly happy to see you in that condition.
I'm happy to be seen.
Yeah, the only thing I'd like to say is that unfortunately Steve is not alone. I heard from George Denyon that he's also in the hospital with back issues, although hopefully he's not going to need surgery. They're going to do spot radiation. We've heard of two.
Excuse me for 1 second, Rick. They're going to give me spot radiation sometime in the next 2 to 3 weeks because there's now room to do it before I leave the rehab. So that's good. That apparently I learned today is almost certainly going to be part of the process in the short term.
So, unfortunately, it is a situation that is common. The more advanced the cancer gets. And the only thing I can say is that Dr. Narayan was amazing in lining up treatment so quickly. And Steve didn't really tell you, but he has been shuffling around. He has feeling in his legs.
Yes.
He's going to be walking. He's going to be kicking ass again before too long. And hopefully we're going to get the prostate cancer under control as well. So,
I feel pretty good about the probability of that. Nobody guarantees anything at any time in this particular game, but it has been a hell of an experience, that's for sure.
Right. Okay. We will hear from you. I'm sure we'll be hearing more about stuff in the future, Steve. I will move on. Jimmy, tell us what's up.
Hello. I'm going to make it brief. My mysterious fevers. Huh?
That's always good.
I know, it's always good. My mysterious fevers, I'm in between, but I have a lot of doctor's on the case, and I have a lot of tests set up. So if it recurs again, especially at that 104 range, then I'm going to go and get these tests because I'm tired of putting my brain on the Barbie every 4 months. My brain is plenty tired of it also. Set that aside. I did have quarterly PSA and testosterone. My testosterone is 730 and my PSA is undetectable.
Hey,
It's now
that's
been
great.
22 months.
Okay.
22 months of that condition. So I met with the MO, which I hadn't met with him for a long time, and he feels that the longer I go, obviously, in this state, then the better chance I have of continuing it. And you know, I love that obviously, but it doesn't change the fact that you know, you still get this anxiety, you still feel like you know, that shoe's going to drop possibly and all that, but you know, you can't fight good news. So that's what I'm doing. That's my story
Good.
today.
That's great, Jimmy. And let's hope that this, you don't get another fever, but if you do, we can nail what it is.
Thanks.
Okay. Joel Blanchette, what's up? What's happening?
Real quick, an update. My PSA has gone up from 4.9 to 6.6. 2-3 weeks ago in the room, I discussed the fact that Dr. Antonucci wanted me to take either the Guardant 360 test or the Foundation One Medicine CDX blood test to find out where my prostate cancer is mutated. Since my last samples that were done at Foundation One are now 11 years old when they did the tumor test on me. So they did put it in last Friday. Dr. Evelyn, my radiation oncologist, sent it in to Foundation One last Friday. Foundation One called me today and said, "Okay, we want to draw your blood. When can we come?" So we made arrangements for my blood to be drawn at 11 a.m. This coming Thursday. And I said, "Well, how long will it take for you to get the result?" They said 14 days. So that's where I am.
Uh-huh.
And by the way, Rick recommended that I go with Foundation One as opposed to the Guardant 360. So that's what I did.
Mm-hmm. Well, let's hope we can figure out what's going on. I mean, does Antonucci have any other ideas about what he might do?
Yeah. Once my PSA gets to 10, he wants to give me 6 months of ADT.
Mm-hmm. I wonder why he's waiting.
Don't know. Well, basically because I have I already found out through the tumor test 4 or 5 years ago that I do have TP53 gene defect and also a P10. And now this new test may reveal some other aberrations in my genes. So I think he wants to put all that together before he makes another decision.
Got it.
So watch this space. I plan next week in the reminder to talk a little bit about some clinical trials that are going on for TP53 and for P10. It's early, it's really early. I wouldn't say that they're actionable, but there are a couple of trials that are out there and a couple of drugs that are out there. And I'm just going to put them in the reminder, and then I'll let our Brains Trust think about them and talk to you about them. As some of you may know, P10, TP53, RB1 are all bad actors, and they're all pretty common in advanced prostate cancer. We have a lot of people in this room, so we can't see hands, but I suspect that there's probably at least a dozen people, if not more, in this room that have P10, TP53, or PB, or RB1, or some combination, including Herb. Don't you have one of those?
I have P53.
Yeah.
So they're not infrequent. I mean, P53 is almost 50% of prostate cancers advanced of P53 mutation. I mean, P10 is less, RBs. So, but again, Rick, I'd love to hear about these trials, obviously, because if these things become actionable, it's going to help a lot of people.
Yeah, TP53 is also common among other cancers, not only prostate.
Yes. Oh, for sure. And
Right,
people,
right.
I mean, people with a germline P53 have something called Lee-Fraumeni syndrome, which leads to a lot
Exactly.
of.
Right, right. And that's where the trials, the trials are being done under the auspices of Lee Fraumeni. And I will include them next week. You know,
By the way, Joe
my
Fraumeni
friend,
and I, Rick, Joe Fraumeni and I share the same barber.
My buddy who was on the group a little while back with the with the lower tract urothelial, he has TP53, RB1, and P10. He's got the trifecta there. So you're right, it shows up in other cancers as well.
Okay. Joe will be listening for future developments.
Right. Thank you.
Okay. Geoff Dreyer, tell us what's up.
Hi, hello. So I finished radiation treatment about 5 years ago, HDR and IMRT and ADT and so forth. And then about 8-9 months ago, I developed radiation cystititis. And I just wondered what people have, what experience the guys have had with this. It was pretty alarming to see. Actually, the urologist prescribed, it was his observation that finasteride helps to stem the tide on this, and it seems to be working. So it's keeping it under control. But it was news to me that this was going to be a problem after, almost 5 years after, or like 4+ years post radiation treatment, I'd be having this sort of problem. So what have other people seen? Is that common?
Was it painful or was it just blood in your urine?
Just blood in the urine and sometimes a lot of it. It wasn't painful.
Right.
Isn't.
So,
gross.
I certainly had the same
Yeah.
thing. Wasn't painful, didn't show up for 4 or 5 years, happened repeatedly. Probably started after about 4 years. And I mentioned it to my urologist at one point, and he said, well, let's see if it happens again. And it happened again. And he said, well, I want to bring you in. I said, really? And I said, I'm not so keen to have a cystoscopy. And he said, well, I'll let you go this time, but if it happens the next time, you've got to come in. Sure enough, It happened the next time, never with pain, but it was just blood in the urine. And so I went in, the cystoscopy was a nothing. I mean, it didn't bother me at all. And he said, yeah, I can see a little inflammation around the bladder. And we didn't do anything and it went away. It's not uncommon. Radiation can take a long, long time to have an impact. So in this case, like I say, not unusual. Now, there are some guys, I don't know if they're on today, but there are guys who have pain from their radiation cystitis. But, just keep your uro well informed and don't get anxious about it. Easier said than done, but I didn't, and it went away. Anyone else have experience with radiation cystitis?
Anybody else?
Today?
Not, I guess not. I mean,
No
what I've
one.
read is that there are
Les is nodding his head. Les,
less. Okay.
Les, have you had experience?
Yes, can you hear me? Yes, I had some toward the beginning, and doctor put me on this pentoxifylline, and that did help the situation. I had that test. I don't know if that's the same one that you did, where they take this garden hose and put a GoPro camera on at the end and shove it up there and turn on the faucet. Is that the
Right.
one?
Yep.
Unfortunately, I don't need a garden hose. Maybe you do, Les.
Oops, what's going on here? Anyway, the pentoxifylline did fix it eventually.
Yeah, I think my comment about this is, having read a little, is that there are actually several different potential treatments for it, and there is a reasonably high success rate of treating it if it continues and it's significant. And I think a good urologist will know about them.
Yeah.
So Geoff, did you have any other questions about this?
And do you know of any mechanism for why finasteride should be a treatment?
Not really. I mean, I think that there are different ways to approach it. It's basically an inflammation. It's basically tissue damage from the radiation. And depending on the degree, nobody really understands the whole picture. So there are a bunch of different therapies with different mechanisms that work.
Geoff, I have a more important question. What is your PSA doing since the end of your treatment, and how's your testosterone, and how's the treatment been?
Well, it seems to be hanging steady. PSA is sort of around 0.2, pretty steady at that level, and testosterone's normal. So, yeah, fingers crossed.
Given your diagnosis was a pretty tough diagnosis, if I remember
That's
correctly.
right. Yeah.
You were a 4+5, and you persevered with our support through that hormone therapy for how long? 2 years, wasn't it?
Yeah, 2 years. Yeah.
And we leaned on you to hang in. Are you happy with the result?
Yes, I am. I didn't I didn't expect this alarming blood appearance of blood, but yeah. Otherwise, yeah. I think I'm feeling pretty lucky actually at this point.
That's good. And when you say your PSA is normal, is it your baseline was 533? Is it back to around that level?
No, PSA.
Testosterone.
Testosterone.
Sorry,
Yeah,
testosterone.
right. Testosterone is I don't remember what the last number was, but it's fluctuates, of course, and it's in the normal range, like 5 to 700.
Well, I'm really pleased. I'm really happy for you that you had a positive outcome, and we try to get guys to hang in and go through the program, and the guys that do seem to have better outcomes than the guys that stop a little bit early. So
Okay.
It's all good news, and hang in and come back and talk to us, but don't let this blood in your urine be too discomforting, and I don't think we know the cause. It's not coming from another cancer. It's not coming from a kidney stone. It's coming from the fact that the tissue is inflamed.
Okay. So we'd like to move on. The Geringers, Steve and Linda. Are you there?
Okay, sir.
Yeah,
Ah,
yes. Do you hear me?
yes.
I just like to comment on two things quickly. One was the endorsement of palliative care. Too many organizations lump palliative care with hospice. Palliative care is fantastic if you've not tried it. It's really helpful. It's about living. It's not about dying. And the first thing my palliative care doctor told me was, you can't make this disease your entire profession. You've got to have a life. And he's been extraordinarily helpful with both choice of meds and just every part that's given me a good attitude. Also, I would just say that struggling with, as men often do, don't like, we're too whatever we think we are, that we would have an emotional. But getting therapy is just it'll unlock your mind, etc. So that's all I got. Thank you, though.
Okay. Do you have any other things to bring up today?
No, sir.
So I just want to make, we've been having some offline conversations with you and Linda. And I do think it's worth, maybe Linda, you want to review, because I do think it's worth you bouncing around these issues in this group and to see what the group has to say rather than depending on what just you hear from me. And if you like, I'd be happy to. Go ahead, Linda.
Just as far as what's going on with our doctor?
Yes, what's going on with your doctor and how do you handle that? Because that's what this group is here for. I mean, exactly the issues that you wrote to me about. I think I'd like to hear what the group has to say about it.
Okay. I will say that Steve ended up in the emergency room this past week with a UTI that had gone to his blood. I had reached out to our doctor probably 4 days in a row and didn't get any answers. So finally we went to the emergency room where they found he had the UTI. And, from what I understand, it could have been a very dangerous situation. So I'm concerned about how to move forward with our doctor. She also made the comment that Steve he's scheduled to have his second treatment of lutetium July 29th. And she made the comment that maybe the new treatment wasn't working. And she hadn't even seen the test results. She had ordered the PSA and had not even seen that it had gone from 44 to 22. This is all pretty daunting for me. I'm learning stuff that I could have gone my whole life without learning, and I'm becoming extremely overwhelmed with it. And I think what I didn't tell you, Rick, was that same scenario had happened previously when Steve couldn't walk. We ended up going to the emergency room, and he ended up having that same surgery, the laminectomy that the other person was talking about. So I spoke with Rick, and he had suggested that we get in touch with this Dr. E in Houston. I did call today, and I found out that we do need to go there. We do need to send Steve's records ahead of time. And I put a call into Dr. Well, I didn't put a call in. Yes, I did. I put a call into his Steve's oncologist just to see how we move forward from here. And Rick had suggested that we get this Dr. E on our team as well. I think that's a pretty good summation.
Yeah, I think it is. And I should add that the young doctor that the Geringers see is a GU medical oncologist, but she's young. She's not that experienced. She's at Vanderbilt. And the question is, where do you find the best quarterback to lead your team? You don't necessarily, as somebody like Peter Kafka will tell you, you don't necessarily have to have the quarterback in your backyard. But it's so important, in my view, that you have a quarterback who knows exactly what they're doing and is following you and cares and is paying attention. And I can understand why Linda was so bothered. The good news that that we didn't mention is that Steve seems to have responded very well to the first lutetium treatment. His PSA came down from 40 to 20, and at the time that the doc said maybe he shouldn't get another lutetium treatment, she hadn't noticed those results. They were in the file. But what do other people have to say about how you make up your team? Herb, go ahead.
Well, I mean, I would certainly, let's speak to lutetium and say that the first PSA reading after your first lutetium infusion can be informative, but it could also may not be informative. For example, mine went up after my first lutetium after 3 weeks. It went up from 3 to 6, and then I got stuck in the morass of no lutetium availability, and so all I could do was get continued PSA tests. And would you believe that over the 12 weeks that I didn't have any, it continued to drop. So you really can't determine. It was really, I'm appalled that she would make this conclusion, make a judgment about or a suggestion on such a flimsy evidence. But she may not have a lot of experience with lutetium.
Well, I think that you got to find yourself a quarterback for the team who thinks the way you do, who has curiosity in the same way that you do, and that will help you process information where there's no guarantees or conclusive answers at any one moment in time, but there is continued diagnostic and thought processes that have to be compatible with the way you think, not necessarily. In addition to that, if you're, you also need to have confidence that they're looking at everything that they're seeing there. And if they're going to tell you why they think you should be, it's not working, what's the evidence? And I would want to hear that, why, how, where, and when. So I certainly had a lot of problems with not really having confidence in a doctor that I've been stayed with for longer than I should have. So,
any other comments? Well, I think seeing Dr. E is going to be eye-opening. Those of us who know her and have spoken to her are just amazed at her abilities and insights. So,
agreed.
So I think it is.
Very good. Thank you so much, Rick. Thank you, everybody.
No, it's a pleasure. And Linda, we could Herb and I talked about this earlier on. We could find some people that are maybe a little bit closer. Maybe there's somebody in Columbus. Maybe there's somebody in Chicago. I mean, not maybe, there are, and that we have confidence in. But the fact is, if you're not going to drive, if you're going to get on an airplane, does it really make a difference? And the thing we do know about Dr. E, and we know it about a couple of the other docs, but we know about Dr. E is she's very, very willing to work with people outside and to collaborate with them. And not all doctors are willing to do that. And so that's why, you're looking on this screen, Steve Saft, Julian Morales. Those are at least two people that have seen Dr. E. There's probably more too on the screen that I'm not picking up right now. But Mike Yancey, another one. She's great. She's great. And if you want to talk to anybody, we'll put you in touch with the Hoovers. They just went down there, and Regina thought she was the best thing since sliced bread. So, we've got people that you can talk to.
Okay, thank you so much.
Please come back and please let us know how things are going.
We will. Thank you so much.
I just went to my local med-onc appointment today. You know, I've got 3 med-oncs, and I haven't fired any of them. I just use all 3 of them. Interesting. None of them have complained about this. They all say, okay, you know, they listen to what I say about each one, and it's fine. So there's no reason you have to fire someone to hire somebody else.
Right.
I do
Peter,
have
you're
one other
next.
question.
Yeah, go ahead, Linda.
So Steve was in the emergency room with the UTI. He's home now, and I'm just kind of wondering, he is scheduled to have this, the next treatment July 29th, and I'm just wondering if he's on an antibiotic, does anybody know what happens if he's going to be able to still get the treatment?
Well, I mean, I'm on lutetium, and I certainly have read the package insert, and it certainly doesn't say that antibiotics are going to interfere.
Okay, thank you.
Thank you.
Could I just follow up for a moment a little bit about the blood in the urine? I actually had blood in the urine for about 40 years, and when I was 65, it was increasing, so the doctor treated me with antibiotics, and at 66, I was diagnosed with stage 4 prostate cancer. So I was just wondering if anybody sort of knows or feels there's a correlation between these things, or is it just a random thing that happened to me and a few other people?
No, look, I think that if you have blood in the urine, you need to be concerned. But sometimes you know where it comes from. I mean, I used to be a pretty aggressive athlete, runner, and I used to train indoors on a 200-meter track in the winter in Manhattan, at Manhattan College in the Bronx. And I would come home a couple of times and I'd have a lot of blood in my urine. Well, I knew that the blood in the urine was because I'd been hammering around that track. My kidneys had gotten shaken up, and that was the reason.
Yeah, no, I understand that.
In Geoff's case, let me finish, Lawrence, and then I'll come back to you. In Geoff's case, we know that he had radiation. And we know that 5 years out from the radiation, 4 years out, 5 years out, 3 years out, it's not uncommon to have radiation cystitis. And he doesn't have pain. Now, if he had a lot of pain and he had blood in his urine, that might be an indicator that he's got a kidney stone or something wrong with the urethra or what have you. So we're not saying to everybody, ignore blood in your urine, but we are saying to men who have had radiation and they have a recurrence at this point in time that it may not be that serious. We don't give the medical advice, but I can only relate my own experience at that point in time.
Sure.
And they finished up doing a cystoscopy, and that's what they found. That's what it was. So it's a different situation. Lawrence, are you new to this group?
No, I've been attending off and on, maybe a few times in the last year or so. But mine was microscopic for 30 years. I was also very athletic. And, eventually it reached a point where it was treated with antibiotics. And the next thing I knew, I found I had stage 4 prostate cancer. And so that was 7 years ago, so it's been managed pretty well, and we just hope it keeps on going.
Okay. So Peter, actually, you're next. Peter.
Me?
You wanted some time.
Hello. Yes. I just wanted to ask a question. Rick came out with his announcement this week, and he mentioned something about a ARASENS trial.
Mm-hmm.
I was going to speak to Dr. Patel, who I'll be seeing next week. I wonder if this might be something I could benefit from, since it's for people who are still castrate sensitive. Any thoughts on that, Rick? or Herb or
Well,
anybody?
I'm going to throw this one over initially to Herb or to Len.
Well, I mean, maybe Len. Len hasn't spoken tonight, so let Len talk.
Okay, guys, can you hear me?
Yeah.
Yes.
Oh, okay. If I recall correctly, ARASENS is the triple combo
Right.
therapy, right?
With
That,
darolutamide.
right. So that's ADT, darolutamide, and docetaxel. Do you understand that that's what's involved with ARASENS, Peter?
Yes.
Yeah.
Right now I'm doing I guess with the Lupron equivalent, what they give you at Mount Sinai. It's not Lupron, but it's that type of thing, and I'm on Abby, and I'm undetectable. And I'm still, I guess, castrate sensitive, and I wonder, should I be trying to be more proactive rather than sit still and wait for the inevitable to happen, or do I try to take action and do something like this at this point before I transition to castrate resistant?
Yeah,
So
I'm
Peter,
not sure that this is the right time for you to switch when you're undetectable. Go with the horse that's winning the race. And my understanding, first of all, as I recall, this trial was in metastatic castrate-sensitive de novo. In other words, these are guys who were just diagnosed from the gate, right out
Okay.
of the gate. That's not your situation, so it's unclear how that would apply to you.
Right.
What
I
do you
may not
think,
qualify.
well, it's not even a trial. I mean, the trial is over, Peter. The question is, would you want to switch from a drug that's bringing your PSA down to 0 to a regimen that includes chemotherapy and a different drug?
Right.
And who's your doc? I forget.
His name is Dr. Patel. He was an associate of Dr. O at Mount Sinai. He interned under him.
Mm-hmm. But you don't see Dr. O,
No, I do not.
because he's the one who switches therapies periodically, or has done something like that. But in the sense of ARASENS, just basically says that this triple therapy had some success, a good success with newly diagnosed patients. But since you're already having success with Abby and ADT, I'm not sure that there's an advantage, but you can talk to your doc.
Okay. Yeah, I see him next week, so I'll mention it to him, this study and this process, and see what he thinks about it.
So, the other thing I would say to you, Peter, is that this trial was really for people with high volume metastasis. And thank God.
I think sadly I do qualify for that, Rick. I have about 5 Mets. I think that's high volume.
Yeah, but that's barely high volume. That's barely. So you're on the margin of between oligo and high volume. And when was the last time you were scanned?
Last year when I got the Azimut, I am getting a PET scan this week.
So let's see how many Mets you have after this, because you've been on the Abbey so you may not be high volume. You may not
Right.
even be.
What would be our expectation, assuming the blood work is indicating that the cancer is being pushed back? So what would you expect the scans to show? Would they be the same as last year or less?
Again, as I had to say to somebody today, I could pull out my crystal ball and I may be I may fill a lot of roles, but Karnak the Magnificent I am not. And I don't know. I mean, I'll turn that one over to the Brains Trust, but I think we've just got to wait and see. But this therapy was for people who came in and lit up like a Christmas tree de novo metastatic.
Right.
Peter, what's the rationale for giving you the PSMA scan when your PSA is undetectable.
It's a PET scan.
Yeah, but
Yeah, I mean, I don't know. I mean, he said it was time to do a reality check, Dr. Patel, but he didn't take me off any of my meds, so I'm going into this scan on Thursday it is of this week, and at least as of 2 months ago, my last blood test, I was undetectable. So who knows? Maybe things changed since then. But
well,
I
let's
mean,
be
I think it might be an Asman type of scan. I know it falls under nuclear medicine. I know I got to go and they give me an injection. I wait around for a while, then I go in for the scan. So
Yeah, but
It,
I would call up Dr. Patel and say, Dr. Patel, my PSA is less than 0.1. What are we going to see on this? Is there any point in doing it? I mean, why schlep all the way into the city? We know you don't see anything until you're at about maybe between 0.2 and 0.5, but probably around 0.65. And for the Axiom scan, over 1. And I think you've got to ask him, what are you hoping to learn
could it
as
be?
your own best advocate?
Yeah, I mean, first of all, I'm able to get this scan at my local hospital in Hackettstown. I don't have to go to New York, so that made it more palatable
Okay.
for me. But
Okay.
is it that he's just doing a reality check? Like, what do you call a staging type test, where they're
Yeah,
going to
but
look at last year's asthma scan and compare it to this one?
you're not going to see anything. If your PSA isn't that high, we know you're not going to see anything.
I'll
You've
call
got
him
to ask the
tomorrow.
question.
Yeah, I'll call him tomorrow because the scan is scheduled for Thursday. So I'll just get a hold of him and say, do I really need to do this? I suppose is what I'm
Well,
hearing.
I don't think that's the question. I think the question is, Dr. Patel, what do you expect to see from this
right.
scan? Assuming this is either a PSMA scan or an Axiom scan, and you need to confirm exactly what scan you're getting. Okay, if it's neither, then this conversation isn't appropriate with Patel. If you're getting a PSMA scan or an Axiom scan, you have to say to Dr. Patel, what do you expect to see when my PSA is less than 0.1?
All right,
Right.
I'll call him tomorrow. Yeah, I've been
Right.
wondering about
I
this.
mean,
I mean,
and
he
then,
ordered 2 scans for me. The other one was a bone density. He's just doing a reality check on that because I have osteopenia. And he's taken over that prescription for me since I switched. So I mean, that's reasonable for him to want to take a look at that because it's been a year since I had that, a year and a half since I had my last bone density scan. So then he ordered this other one at the same time, and I'm like, okay,
Well, it sounds to me like this is a glucose-based scan. What do they call those scans, Herb? That's that CT scan. What's that? F18, yeah, no, or whatever it is.
the
That it's
FDG.
not a PSMA scan.
okay.
so, anyhow,
Okay. I'll call him and ask him exactly what am I going for and is it really necessary or what does he expect to learn from this?
right. So we're
Okay.
getting late. Obviously, we'd hit 10 o'clock and we've lost some people, unfortunately, but there are a few more people who are still on my list. So certainly I'll stay and we'll stay as long as necessary to
So
make sure everybody
I'm going to
gets
say
taken
goodnight.
care of.
I'm running out of gas. It was a really
Okay,
interesting
Steve, we
meeting on so
expected,
many different
yeah, be
levels.
well. We'll talk to you
Thank you.
soon.
Be
Bye-bye.
well,
Talk to you
Steve.
soon.
Be well.
So there are like 3 more people left. So I'm going to try to move through them. And, if you stay, it's great. So, Mike Yancey, you had something to add.
Yeah, I just want to give a brief update. Of course, just get a little background. Saw Dr. E the first time, May 24th, 25th. Did a Polarify scan and had very strong PS. So she decided to move forward with getting me on Pluvicto. And so I've got my first treatment scheduled for August the 9th. In the meantime, we also did a Foundations 1, somatic test on the bone scan, or excuse me, the bone biopsy that I had done a year ago when I was in the hospital. And we've also since then done a liquid biopsy by then. So basically, real quick, I've got 8 mutations, and there were 6 on the bone biopsy and the same ones on the liquid plus 2. The main thing I want to point out is, and thanks for the setup, Rick and everybody, is that one of the things we found is I've got a P10 mutation, RB1 mutation, a TP53 mutation. So anyway, we'll see what Pluvicto does for me and how it'll work. So that's kind of the update. Thank you.
Well, that was fast. So how was your reaction to Pluvicto? Have you had your first one yet?
No, that's August the 9th.
And what's your current PSA?
Well, that's another thing is that my PSA from Dr. T's perspective is my does not put out much PSA. My last, it had been inching up ever so slowly from 0.07, and the last test I had, which is about 2 weeks ago, it was at 0.9.
0.9. And did you have you had a PSMA PET scan? You had a Polarify?
Yeah, I had a Polarify, and then I was also followed with the gallium-68 also, so I've had both.
And so the Polarify showed that you have a PSMA avid lesions. I'm sure otherwise she wouldn't be prescribing Pluvicto.
Yeah, strong expression on the PSMA.
So, but
and I've also had a lot of bone things come back too. So.
Right. I think that a conversation with Dr. E about the results of your foundation medicine would probably be very worthwhile, because she's going to be very much up on these various trials that are available for TP53 and for P10. RB1, we really don't have anything on, as far as I can tell right now. It's a trifecta of bad actors. I said that before, and so I have to say it again. But we're really working on them, and it isn't surprising that a man with a fair amount of metastasis and a very low PSA exhibits those 3 mutations. And I can't think of too many GU medical oncologists in the country who you're better to be with that trifecta than Dr. E. I mean, there are some other very good ones, but I think that if you can get hold of her and set up a time to chat with her. I know she's back from Greece, and she's back in the office today for the first day. But maybe next week you can have a conversation with her about it and tell us what you learned.
She's already seen the bone biopsy results, and we had a brief discussion on that before she went on vacation.
Oh, and what did she say, Mike?
We're going Pluvicto right now. We may look at cabitaxel and carboplatin at some point along the way, but right now we're focused on the Pluvicto started.
Okay, well, there you go.
Right. Okay, well, we'll keep on top of this.
Thank you.
Moving on, we have Dennis Correa. You're still with us, Dennis, so we haven't forgotten you.
Thanks, Herb. I'm still here too. Just an update on the what I call my annual checkup with my quarterback, Dr. Singh, at Mayo Clinic in Phoenix. They did the head to toe technetium bone scan, and then they did the CT with contrast through the abdomen, chest, and pelvic areas. And another reason, a couple of reasons for doing this on an annual basis. One was, this concern of neuroendocrine cancer, that morphing of the adenocarcinoma to neuroendocrine. And, my PSA is non-detect. My testosterone is not detect. And, I'm feeling pretty good. I'm doing okay. But the neuroendocrine is a nasty thing. And it doesn't express PSA, obviously. So the only way really is with scans like this to look for something that wasn't there before. The other reason I had for doing this was that I had recently with the small bowel obstruction, I was hospitalized for 2 weeks. During that period of time, they did a number of x-rays, MRIs, and so forth of the abdomen. So when I wrote the report, they compared it to some of my older scans that I had done here locally in Tucson, where they found the lesions, the bone lesions, so forth. And the comments were, looked like there were some new lesions and here, there, whatever. And so there's a lot of inconsistency. So I wanted to also get that straightened out, and which we did with the test up at Mayo. And basically what they were seeing was either scar tissue left over from some of these lesions that had been since treated and were actually not expressing anything at this time. So I had a good result. Came back, says, don't need to do anything further at this time. I raised the questions about the lutetium stuff and the darolutamide and bone strengtheners. And he says, no, none of this here is going to do anything for you at this point in time. So I'm just going to keep cruising.
Right. That's a good idea.
Yes, and I would just like to give a vote of thanks to Mr. Correa for buying me lunch today.
Oh, well.
Which he was able to do after he got up at the crack of dawn, got down to the golf course for a very early tea time. I don't know what there's 7, and he was done by 11, and he played a full round of golf today. By his reckoning, not his best, but he had some good shots, and we love it. We love it when we got a man with advanced cancer who was in the hospital with his gut in a twist just a couple of months ago, and he's out playing golf. And I say, great job, Dennis. And it was lovely to see you.
Thank you. Same here, Rick.
Okay. Glad to hear things are going, Dennis. And finally, Richard, thank you for waiting.
Okay. If you remember right, I've got the high-grade foamy gland prostatic carcinoma, which is rare. Anyway, stage 4, and it's metastasized to the lungs and the lymph nodes, abdominal and pelvic. And anyway, I went through the 6 rounds of chemo and just finished that, as well as the ADT. And basically, there's 135 nodes in the lungs, and they've reduced in size. They've got a few larger ones they've used as benchmarks that 6 millimeters, they're down to 4, but they're still there. And basically, it's good news. And I had a CAT scan last week, obviously, and a whole body bone scan, and there's no metastasis to the bone. So basically, I won't say it's going backwards, but it's there. There was a review by the ANOVA Oncology, including who's the doctor, the head of the department. You know her.
Aragon Ching.
Yes, thank you. And then with Dr. Markowski up at Johns Hopkins, and basically they're saying forget about the PSA, although the PSA numbers are getting better, but I've never had it above 2. And testosterone is down to 17, where back in February when I was baselined, it was 426. So, and then they're just saying, hey, let's, rather than try to use PSA as an indicator, just go to the scans every quarter and track it that way and stay on the ADT. So it's been good.
So basically, the going forward, it's simply ADT.
For the next quarter. After 6 rounds of the chemo, that gets hard on you.
Right.
And my white blood count was going down. So want a little bit of a relief there. So anyway, that's been the good news.
Are they adding a second-line anti-androgen, Richard? Are they adding abiraterone or enzalutamide or anything like that? Not right now.
That's an option that was brought up, but right now, and Dr. Allen is right now the quarterback.
What's the reason? Why are they not doing that? I mean, I think that would probably be because you still have a lot of metastasis in your lungs, correct?
Yes. And hopefully the ADT is the agent that is, if you will, that is to reduce it. I asked that question myself.
I mean, one would think that for the best result right now, if you're strong enough and capable enough, that adding a second line anti-androgen, I think would be the protocol. And if they're not doing that, I would be challenging them and saying, why are you not doing it? I don't know. I mean, what does Herb or Peter or Len think about that? Have the metastasis in your lungs reduced as well, or not?
Yeah,
what's happened
they
to
have.
them?
No new metastasis, and the size of the nodules is reduced.
So
go ahead, Len. Herb.
Well, I guess I would echo what Rick said, but I guess the question is, are they thinking that basically they're going to give you a little more time for your white cell count to come back? And have they discussed further chemo, or because of the fact that it actually is working? Or Or is it just 3 months of ADT and then we'll see?
That's basically 3 months ADT scans, and well, it's in September, and then go from there. Because I brought up the Anatrol, and that was what they're saying right now. Because everything I'm reading basically said just the opposite.
Right.
Richard, did they give you the shot to keep your white up during chemo?
No.
No, really? Huh.
Not that I know of.
It's usually an automatic shot. They put a patch on your arm and inject you a day later to stimulate your white blood cell production during chemo.
No, it's only been the 6th round, I've got to admit, that it went down that far.
Right, but it's
It
pretty
went down
standard.
to I think 1.8.
Maybe I'm missing something, but it's pretty standard to. I can't think of the name of the drug right now. I'm having a brain fart.
Neulasta.
Neulasta. Yeah. It's almost standard drill to give you Neulasta with your chemo infusions.
I had docetaxel last week, and they certainly gave me that device that I wore for 27 hours and
Right.
delivered that dose.
Right, because there's a big concern about your white blood cell going down, and you don't want to be left vulnerable, particularly in this day and age. You might ask about that. Maybe they can do it after the fact.
As it turns out, it's back up as of today, because it was tracked again today.
Mm-hmm.
It was, I don't have it here, but it was back in the above 4.
Uh-huh.
That's good. Okay, that's good range.
So it's moving up.
Yeah,
Good.
it went up very quickly.
Yeah, and that's really positive. But I think I would want to get from them in writing in the portal why it is that they don't think you are a candidate right now for a second-line anti-androgen. So a second-line anti-androgen means usually one of either abiraterone, enzalutamide, apalutamide, or darolutamide. It's one of those 4. But if you just say, please could you explain to me why I am not a candidate for a second-line anti-androgen, since that seems to be the norm for somebody with as much metastasis as I have, then you'll get a written response and we can talk to you about the response.
Okay, that's fair.
Yeah, I mean, I think it's a very good question. And also, what, given that you have the lesions are shrunk, but then they're still there, what are their plans to get rid of them?
Right now, just continuing the ADT at this time.
Mm-hmm.
And if that is, if I'm the hormone sensitive, and that's what's doing it, then that's how they'll go away.
Uh-huh.
So
but I
have you
don't
ever
think
had
there's
a
an
PS?
awful lot of feeling that they're going to all go away, and particularly since the involvement with the lymph nodes as well.
Have you ever had a PSMA scan, Richard?
No. Listening to what
Couple of
you've
things.
been saying, by the way, the PSA numbers since, well, I was baselined before any treatment at 2.05, and now it is 0.166.
So there's a couple of things that occur to me that I would be wanting to raise with them. The first is a PSMA scan is I don't know how this what type of scan are they giving you right now to see these lesions?
It's the CT.
Some type of CT scan, right?
It's a CT scan. I'd have to go to
So
with a CAP.
yeah. So your PSA is low, so there's reason to say, well, there's no point in a PSMA scan. But there again, your PSA has always been low. And what we really want to know is, do you express PSMA? And we would, it's better to know that sooner rather than later. So you should be asking them, not can I have a PSMA scan, but how are we going to determine if I express PSMA? Because I would like to know if I'm a candidate for Pluvicto. Now, it could be with your type of cancer that you don't express PSMA. It's quite possible. But you need to ascertain with them whether you do or you don't express. Secondly, have they done any genetic testing?
Yes.
Or genomic testing?
Both. And the answer was they did not match to any of the mutations that
no actionable mutations. They saw no actionable mutations.
Yeah, on both cases.
Right. What type of genomic scan did they do? Do you know who did the scan?
Tempest.
Okay, so that's really good. And Tempest didn't find anything.
Didn't find anything. They tried matching it against 85 gene panel, and they didn't match anything.
Okay.
And the gene.
Okay. So I think the question I would have for them is, what are your plans to find out if I'm PSMA sensitive? So there are two things. One is, why would I not be a candidate for a second-line anti-androgen? And how do you think we might be able to determine if I'm PSMA sensitive?
Right, and a candidate for Pluvicto.
Yeah, matter of fact, that was one of them that I put on the list when my written list I gave him.
Right.
So what I would put those questions in the portal. I mean, certainly, if do you have is Markowski? Do you communicate with Markowski directly, or through Aragon Ching?
I can go to him directly because I went to him to get the second opinion back in February. So
then I would ask them both the same questions.
Okay.
And I know it's really late, but there's one little piece of business I think I'd like to cover. I think the Geringers, are you still with us, Linda and Steve?
I don't think so.
I just made it. My battery's gone.
Okay. Just hang in. And Russell, Hoover, are you there?
Yes, I
Mr.
am.
Hoover,
Yes.
would you like to just just voice your experience with Dr. E for the Geringers, because they're thinking of going to see the Geringers?
Do it. That would be my initial thing. No, I mean, she knows what she's doing. We walked in and sat down, and when she walked in the room, she had no paperwork in her hand, but she knew everything about me. And we spent the better part of 2 hours that first meeting, and got things lined up, and came back the next week for more tests. In fact, I'm meeting with her tomorrow. What do you call it? I always want to say Skype, not Skype, but anyway.
Telemed.
Telemed. I can never get that word. We're meeting with her tomorrow afternoon, and I've had other blood work and tests done here in Florida, which have been forwarded to her. The way I'm looking at it was the tests and stuff that were done in Houston while we were there a month ago were a baseline for her. Now we're getting secondary blood work and tests done here in Florida to see what, if anything, has changed. Because I look at everything as these tests, no matter what they are, they're like a Polaroid. That means this is where your body is right now today, and the body's always changing. So you need another point of reference to say, is it staying the same? Is it getting better? Is it getting worse? And what do you do? What ifs? So these are the things that I derived from Dr. E's attitude that I have never found anywhere else in any physician. So yeah, if somebody wants to go, I would say absolutely go.
Great. Thank you very
Okay.
much.
So
Okay,
look,
thanks,
it's
Russ.
getting late.
Okay, we need to go. Otherwise, it'll just be you, me, you,
Right.
Bob, and Peter, and Len, and
Right.
Joe. Just be us moderators. Okay.
Right.
I think Peter's gone to sleep. Look, his head hasn't moved forever.
Peter's,
Oh, no, there you go. Okay. Yeah, okay.
by the way, my update for
I'm
those
just multitasking.
for those that don't know, by the way, I came back from my latest trip with COVID.
Oh no! You should have told me. I would have put my mask on.
Superb. Yes, I did too. Okay, on a 60th high school reunion, and I came back with it.
So,
What are your
luckily
symptoms, Herb?
the symptoms are just like a cold. So
Yeah.
a mild cold. So I didn't have
Amen.
a sore throat, didn't have a headache, didn't lose taste or smell, just basically a cough and a runny nose. So in that
It's
sense,
just
I'm
rest.
lucky. I'm sorry, Len?
You're just resting, no other therapy.
Right. I decided what I've read is that if you take, I forgot the name of it, the
Paxlovid?
antiviral, Paxlovid, and you're mild, it just makes things worse.
Yeah. Yeah, you can have a relapse.
So at any rate, I am not wearing my mask, but I'm up in my room being isolated. All right, I'm going to stop the recording.
Okay.
All right, guys.